Welcome, everybody. We're just going to give it a few minutes before we get started. I see a lot of people are joining, so thank you. For the sake of time, I'll go ahead and get started. Hello, and welcome to our webinar, Overview of Treatment Options for Adults with Tourette Syndrome. My name is Marissa Hsu, and I am a program lead at the Tourette Association of America, and I will be your moderator for tonight's webinar. During this webinar, participants will learn about the different available medical and experimental treatments for adults with Tourette syndrome and tic disorders. Dr. Deeb and Dr. Cohen will provide information about the available treatment options along with the evidence for each treatment. Participants will have the opportunity at the end to ask questions of the speakers. Please use the chat function to relay your comments and questions to the speakers, and I will address them at the end of their presentation. At this time, it is my pleasure to introduce our speakers for this webinar. Dr. Wissam Deeb is a neurologist and assistant professor at the UMass Chan Medical School. He completed his MD in Lebanon at the University of Balmain, hopefully I said that correctly, and his residency in neurology at the University of Massachusetts in 2015. He then moved to the University of Florida to pursue a movement disorders fellowship and then stayed there in faculty until June 2020. Dr. Deeb has a clinical and research interest in Parkinson's disease and Tourette syndrome, focusing on incorporating technological advancements such as wearable devices in clinical and everyday care. Dr. Eric Cohen is a part of a multi-generational chiropractic family and has served Palm Beach County, Florida for over 35 years. He completed his doctorate in chiropractic medicine at the Palmer School of Chiropractic in Iowa in 1985. Along with doing gentle chiropractic, Dr. Cohen also does craniosacral therapy, functional endocrinology, botanical medicine, and homeopathy. He has experience treating adults with Tourette syndrome, including his own wife, and other comorbidities associated with Tourette syndrome, such as anxiety and autism. In his spare time, he plays bass in some local bands. Without further ado, I will turn it over to Dr. Cohen and Dr. Deeb.
Thank you. So we're going to discuss today the treatment, going through a quick overview of the different treatment options for adults with Tourette syndrome, and we'll be happy to take your questions. So this is just a quick disclosures. There's already mentioned that I manage people with Tourette syndrome, so some of the information is also related to how I do it or how I do manage people with Tourette syndrome. And that because there are some areas where there is like a little bit of variation between people. I am also on the TA Adult Task Force, but otherwise I have no financial conflict of interest with this presentation. And also Dr. Cohen has no financial conflict of interest. So as you all know, I'm pretty sure most people on this talk already know quite well what is Tourette, what is Tourette syndrome, a disorder that can present in childhood. And then, as you can see here in this graphic, it usually starts around the ages of 7 to 10. And then as the person becomes older, the manifestations can change. Especially in the teenage years, there might be more impact or more effect of the multiple comorbidities. The tics can become complex. Now, for most individuals, and we're going to see the statistics for that, for most individuals, the tics decrease a little bit or start decreasing during adolescence, but most people continue to have tics into their adulthoods, as the panel C and D show, as well as the continued effect of the different comorbidities. We also know that Tourette syndrome is a highly genetic disorder, and some studies have indicated up to 92% association of genetically, and that is quite commonly observed in people with Tourette syndrome, that strong genetic association. Now, in terms of the what we know about some of the features of Tourette's is that we know about something called urge, which is that feeling or sensation or need to do the tick, and that's not present in everybody. In a small study, including only 21 adults, around 2/3 of people had a consistent urge before their ticks, not everybody. So using the urge for treatment sometimes might not be good for everybody, and we're going to see why this is important to take into account. The term coprophenomena, so that's saying bad words or bad gestures, occurs on 28% of people, and self-injurious tics occur in around 17% of people, which is important to highlight because usually most people, when they think of Tourette syndrome, they think about these two phenomena, but they are not as common as you see here. And then if we look about how tics persist into adulthood, there's also a misconception in the population that Tourette's is a childhood disorder, but we know that most tics persist into adulthood for most individuals. And this is a large study from the Danish National Tourette Clinic data, including 314 people. The average tic severity did decline in adolescence by around 0.8 points every year on the scale called YGTSS, the Yale Global Tic Severity Scale. But only 17.7% of the people did not have any tics above the age of 16. So most people continued to have tics. The large majority, around 60%, their tics were mild, but around 23% had moderate to severe tics. And you can see also a similar trend in the other comorbidities with the tics, and this would be something like ADHD or OCD symptoms. This is just a quick overview just to make sure everybody's on the same page with this information before we delve into the treatments. And whenever we're thinking about treatment, we want to understand what we call the pathophysiology of the disease, what is the driver of the certain disorder, what causes certain symptoms, so that we can treat them appropriately. And as you can see from this graphic, in Tourette syndrome, we are dealing with multiple areas or multiple parts of the brain that have a change in their response or a change in their processing, and that could be the basal ganglia. See, we might hear of that term, basal ganglia. These are the deep gray structures inside the brain, and these are important for both tic generation and as well as the comorbid symptoms such as, let's say, OCD. There is a role of the frontal lobes, the front of the brain, especially in tic suppression, when a person is trying to suppress their tics in a certain situation, or in the treatments that we consider, such as the behavioral therapies. There is the motor cortex, which is important in creating or moving the tic so that we have the movement. The sensory cortex, which seems to have what we call disinhibition, so a difficulty in stopping the signal from making it to the other parts of the brain and allowing the urge and the tic to happen. And then multiple modulators in the brain, most importantly is dopamine, but also other ones like norepinephrine or noradrenaline, which are also very important. And these are the basis of most of the pharmacologic treatments we use, and that's based on that understanding of that complex interaction of these different brain systems together that cause disinhibition and then facilitation of movements, so that movements happen much more easy in people with Tourette's compared to people who do not have Tourette syndrome. So I'm going to start initially speaking about the behavioral approaches for treatment. Then we're going to go to the pharmacologic treatment. Then Dr. Cohen will review with us some of what we consider to be the alternative and complementary approaches. And then we'll finish with some non-pharmacologic approaches, such as stimulation devices. And then we'll be happy to take your questions at the end. So for the behavioral approaches, the behavioral therapy that is most well known and has the best evidence is something we call the Comprehensive Behavioral Intervention for Tics, or CBIT for short. It includes two components. It includes habit reversal therapy, which is based mainly on increasing awareness about the urges, increasing awareness about the tics, and then competing response, which is a technique to help decrease or suppress the tics long term. This technique is currently recommended by the TAA and multiple other organizations as the initial treatment option for people with Tourette syndrome. And the effect varies by age, but it is around 26 to 31% decrease in the tick number and the severity of the ticks. But it seems that it is possibly more effective if the person is doing CBIT without being on medications. From some studies, it shows that being on medication decreases the effectiveness of CBIT. So if people have a little bit milder ticks or moderate ticks and they don't need to be on medications immediately, then CBIT by itself might be a little bit more effective than combining it with medications. This is a summary of the evidence of using CBIT. So this is CBIT compared to psychoeducation and supportive therapy. So just simply mainly education about Tourette's and then how it evolves over time. And then we can see that 38% of people in the CBIT group were responders to the treatments, compared to only 6.8% in the psychoeducation group. And then 80% of those initial people who responded to the treatment continued to be responders at 6 months. So the effect of CBIT is not only short-term, but can persist over time. And that has been observed both in clinical trials, but also outside of clinical trials in clinical practice. But there are limitations in CBIT for sure. First of all, not everybody responds. There is also limitation in accessing CBIT in the community because it has to be provided by a certified therapist. So there is some efforts in order to make that more accessible, whether it is by providing tele-CBIT or having a CBIT approach that is purely online. So there is a website called tickhelper.com, for example, but also there's efforts to see if we can do group-based CBIT. And this was a study that was published quite recently to assess if we can do group-based CBIT for people with Tourette syndrome and chronic tic disorders. And then in that study, although it is a pilot study, which means that the number of people that were there is small, but it still shows us that 83% of people who engage with this group therapy approach had a 25% or more reduction in their total tic severity score, which is considered clinically significant decrease, which is a very big number to observe there. Hopefully, as this is just published, so hopefully as we get more studies, we'll see if this group-based CBIT for adults with Tourette syndrome can be quite effective and then allow more people to access that resource that is a behavioral non-medication option. Another technique other than CBIT, which is, I think of it myself as a complementary technique, is mindfulness-based tic reduction. And that work started a few years ago, initially with an open design study. So there was no sham or no control group for this study. And with a small number of participants, they got 8 weekly 2-hour classes and 1 4-hour retreat. And most of the people there felt quite good, and there was improvement in the tic severity and impairment at 58.8% at 1 month. To note, there were 2 people who felt that the intervention caused their tics to worsen, but most of the individuals felt that they learned a lot of good skills to help manage their tics, but also some of the comorbidities such as anger or anxiety. And then also they felt like almost like growing pains to acquire the mindfulness technique. And they described it as the ache that comes with that technique to get to be comfortable with using it. In 2021, the same group published a feasibility study of doing the mindfulness technique online. And that online approach showed only moderate improvement in tics. And then there was also poor compliance. And that could be because of the technique being online. It is harder for people maybe to engage in a mindfulness technique. Currently, there was a protocol published for a randomized controlled trial to check this technique in children, but we don't have the results of that study at this point. But these are the main 2 approaches right now that that are assessed for behavioral therapy, and that is the CBIT, which has most of the evidence, as well as mindfulness-based tic reduction. There's other techniques like exposure techniques that have also been studied, but there's not as much evidence for them right now. So going to pharmacologic treatments, we're going to look at this algorithm that we commonly think of when we see individuals with Tourette syndrome in the clinic. So not every person with Tourette syndrome really needs any treatment. As you know, like the tics are not by themselves pathologic, and then some individuals might only benefit from psychoeducation because tics are not interfering with their lives. And in that case, they might not need treatment in terms of pharmacologic treatment. But if they need treatment, we think about an artificial division really between pure tics or tics with comorbidities. And the reason we do that distinction is that it affects our choice. Now, the options I'm going to share with you here vary a little bit or sometimes a lot between different providers about what is considered first line versus second line versus third line. But for most individuals, if we're thinking about mild to moderate tics, and that will be in terms of how much the tics affect their quality of life, we usually start possibly with behavioral therapy such as CBET or behavioral therapy with another agent. But for most people, we can do, if it is mild to moderate tics, we can start simply with the behavioral therapy and then assess response in a few weeks. Usually we have to give the behavioral therapy maybe 4 to 10 weeks to assess if it's helping. And if it is not helping, then we can consider a group of medications called the alpha adrenergic agents. So some of those will be clonidine and guanfacine, and we'll discuss these a little bit later in more detail. And then also we have to wait a period of time. Many patients might not wait the duration, and then we really don't assess them quite well. So usually want to wait at least 4 weeks, but preferably 4 to 6 weeks. If these don't work, then in that case, we would consider neuroleptics. So these are medications like aripiprazole or risperidone for management. And this is where there is a lot of variation between different providers. Other individuals might consider in that stage other medications such as the VMAT2 inhibitors. So these are like tetrabenazine, valbenazine, the tetrabenazine, or might consider clonazepam, topiramate, or botulinum toxin. So there is a little bit of variation here in terms of which one happens first and then at what level. Okay, and then if these types of approaches don't work, then in many cases we would consider combination of treatments or combination of medications, as well as considering what we call first generation neuroleptics. So these are your older medications such as pimozide, fluphenazine, haloperidol. And then if there's still no benefit, then the person meets criteria for what we call refractory Tourette syndrome. And in that case, we can consider clinical trials, consider cannabinoids, or consider non-pharmacologic treatments such as deep brain stimulation or other non-invasive stimulation such as transcranial magnetic stimulation or direct current stimulation, which are currently, the last two are currently still in early studies. So that's usually the approach. As you see here, for most of the treatments, we need to wait multiple weeks. Minimum usually 4 weeks, but for some of them we can go much longer, like around 10 weeks, before we can say that this medication did not work. And then this is a similar way of approaching the management for people with comorbidities. But sometimes in that case, you want to start by considering the treatment for the comorbidities, and then maybe change the order of the treatment depending on the intensity or the impairment associated with the comorbidities. So for people who have a lot of OCD symptoms associated with their tics, we might consider these neuroleptic agents like the aripiprazole or the risperidone and other similar agents. We might consider them much earlier than we would usually consider for other individuals. And then people who have more ADHD symptoms, we might consider the alpha adrenergic agents such as the clonidine, guanfacine more than other agents because they can help with those symptoms better than other medications. So that's a quick overview of how we think about management. Again, as I said, this is not set in stone. This is like a guide, and then the order of these agents is very different for different people, but also for different providers. That's going to change between us. Now, if we look at what are the FDA-approved agents, there are only 3 FDA-approved agents for Tourette syndrome specifically, and that's haloperidol, approved for people above the age of 3 years, and pimozide for people above the age of 12, and aripiprazole is approved only in the pediatric population between 6 and 18 years. But we use much more than those medications. So most of the medications that we use and then that I spoke about, we were speaking about, are going to be medications that are beyond the FDA approval list, and so they will be used as off-label indications. So if we look here, this is a recent meta-analysis. So they looked at all the different studies that have been published to date, and this one was published recently in 2023, and the beginning of this year. And then it looks at 2 ways of looking at the different medications that have been used. First, by grouping them into class. So this will be, for example, the neuroleptic or antipsychotic drugs. So that will be the red. I'm going to just put a laser pointer here. So that's the red dot here. That's your medications like aripiprazole or risperidone. The green dot here is your first generation, which is your haloperidol or pimozide. And you can see here, if you can look at the number of patients in these studies, they are the highest, the most studied medications. Then there are other medications like the alpha-2 agonist, that's your clonidine, and then guanfacine, that's the yellow one. Traditional Chinese medicine, we're going to speak about some of those medications, also have a large number of people studied here. And then the VMAT2 inhibitors, these are the tetrabenazine, valbenazine, dotetrabenazine medications, and then also medications that increase dopamine, which is different or the opposite of those medications, have been studied only briefly for Tourette syndrome. Now, if we look at the different medications themselves that have been studied, that's in the lower graph, and this will be the different medications that they have looked at in these studies. And you can see here, like pimozide, for example, haloperidol, guanfacine, clonidine. You can see some of the Chinese medicines like Ningdong, which we're going to review, but there are multiple others that have been studied. There is ecopipam, which is a medication that's currently in clinical trials, phase 3 studies to evaluate its efficacy. And there are other medications that have been, as you can see, studied in a smaller number of studies. So these are, like, if we compare the different studies that are currently available for Tourette syndrome. And this is an excerpt from this study showing effectively the main conclusion from the study. This main conclusion shows that the medications that seem to be the most effective at this point with the level of evidence we have are the first generation neuroleptic and second generation neuroleptics. These are the antidopamine medications. So these would be like the haloperidol, the pimozide, flufenazine, or the second generations like the aripiprazole, the risperidone, and other similar medications. And then other ones that are also effective are the alpha-2 agonists, so that's the clonidine and guanfacine. But if you look at the number here, which is the mean difference or standardized mean difference, for the second generation, it's in a difference of 0.71 or an improvement by that much. And then for first generation, 0.65. But for the alpha-2 agonist, it's only 0.21. And this is comparing it to placebo. So the first and second generation antidopamine medication or neuroleptic medications are almost the same efficacy, but they are much more efficacious or beneficial than the alpha-2 agonists. And this is something that's not surprising, but this meta-analysis showed us this information quite clearly. And this is also a more detailed view of these medications and then the level of evidence we have right now. So this is a very busy graphic to look at. So it shows each medication and looking at how much that medication helps the Tourette scale or improves the symptoms compared to placebo. And then the more the number is, or the more the graph goes to the left side, so more goes this way, the stronger the effect. And more it goes this way, then this means it favors placebo, or it is almost the same as placebo. Now you also see different colors here, and this is the quality of the study. So not all the studies are equal, and there are multiple factors that go into that. So assessing like how much bias there is, how much blinding could people tell that they're getting the real medication versus placebo, and then multiple other factors in how people were selected for the study and how they were followed, and then how many people dropped from the study, and then how much was that accounted for. So there are multiple factors that go into account to determine the quality of the study, and that gives us a level of certainty of evidence. So not simply the effect of the medication by the study, but how reliable that effect is. So red means that we have low certainty or very low certainty of evidence. Yellow is low certainty of evidence, and blue is moderate certainty of evidence. The only caveat I would give here is that for the Ning Dong, I think we can, with the level of evidence we have, it will be between yellow and blue rather than red. But other than that, I agree with the other classifications here. Now, as you can see, there's a lot of medications here that we commonly use in clinical practice. There is like topiramate, ziprasidone, aripiprazole, risperidone. Thiopuride is not commonly used in the US, but it is available outside in Europe. Haloperidol, pimozide. Ecopipam is from one study at this point, but there is an ongoing clinical trial right now. Now, for other medications, some of them we use all the time. You can see here clonidine and guanfacine. The effect of those medication is barely better than placebo, but as you can look from other ones, that effect is helpful mainly for the clonidine and the more than the guanfacine because there's more studies. So despite that it is not as strong as the other medications, we still use it because of the difference in the side effect profile. And that will be seen here in the adverse effects, so how much people can tolerate these medications. There's a lot of variation, and you can see that line here is that there's a lot of variation between different people. But then as we go to many of the medications that are most efficacious, there is usually a little bit, as we'd expect, more side effects than in placebo. And then also how many people accepted or like how much they can take these medications. Also, there is a variation in that, but most of these don't seem to be significantly different from placebo. So most people tolerate the medications okay, but again, huge difference. Some people tolerate the medication okay, like over here, but then if we look over here, many people here could not tolerate, over the other way around, could not tolerate the medication as well. So it varies a lot from person to person, but if this is again averages, and then we can see that most people tolerate the medications okay or accept them in these clinical trials. The same thing here is in terms of the adverse effects, they tolerate them. But again, all these clinical trials are usually short term, and then many of the side effects of these medicines are long term. So this does not give us the full clinical picture of how people tolerate the medications. So I'm going to go again into the most commonly used medication and discuss some of their major features. So the alpha-2 adrenergic agonists, so these are your clonidine and guanfacine. Again, as we saw, they can help people and they have an effect better than placebo, but it is on the mild to moderate effect. The way they work is they work mainly on the sympathetic nervous system, and that's noradrenergic or noradrenaline system. And that's why in that first slide, I showed the effect of both dopamine as well as that system. So clonidine has a higher level of evidence. So the evidence is currently considered moderate confidence. So we're moderately confident that the evidence we have is supporting it. Guanfacine has a lower level of evidence. But despite that, you see that guanfacine is maybe more commonly used in clinical practice than clonidine, despite that difference in level of evidence. And the reason for this is that they're quite similar molecules. So we think that difference is simply because of the difference in the number and quality of the studies between the two. And then also guanfacine might be less sedating, but I commonly use both agents quite equivalently for people. In terms of side effects, the most common ones are sedation, dizziness. Some people become irritable on those medicines. They can be headaches, as well as hypotension, because these medications were originally produced as antihypertensive medications. The other groups of medications are what we call GABAergic. So they work on the GABA in the brain. And then many of these medications are anti-seizure medications originally, but have been studied in Tourette syndrome. So the one that has the most evidence is topiramate. The brand name is Topamax. And there is one randomized study, and then a few retrospective studies that showed that it is possibly has benefit compared to placebo. The dose that we usually have to use for this medication is higher than many people might be taking for topiramate. So usually the average dose from the study is 125 milligrams. So usually you need to be above 100 milligram to have a benefit with this medication. Many people I see might have taken topiramate, but a lower dose. So before we say that this medicine didn't work, we have to increase the dose. The main side effect of this medicine is weight loss, which is unusual compared to the other medicines, which cause usually weight gain. It can cause decreased appetite, kidney stones, and then at doses above 100 can cause word finding difficulty. So if that happens, the word finding difficulty, we usually will have to cut off this medication. There are other medications that work similarly on this GABA system in the brain. This would be another seizure medicine called levetiracetam, or Keppra is the brand name, but there's insufficient evidence right now to recommend it. Same thing with clonazepam and baclofen. Sometimes I use these last two as rescue treatments, and that to help with like paroxysms of tics, or when there is significant worsening of tics because of an acute event, they can be helpful for short term. Baclofen seems to help with the pain and the spasm associated with some of the tics, but doesn't seem to decrease the tics primarily, but it can help tolerate the movements a little bit better. And then the most effective class that we have is what we call neuroleptics, or it comes also in the name of antipsychotic medication or antidopamine medications. So these work by blocking dopamine, which seems to be a major driver in causing tics or causing their developments. It is the most effective tics class, as you saw in that previous summary slide, compared to other medications. And they have side effects. Some of them are short term, such as like sedation, but they can also cause weight gain. They can cause increased blood sugar and cholesterol. They can change mood because these medications are mood stabilizers too. And then the most feared complication is tardive dyskinesia, which is not common in Tourette syndrome. We still don't know why it's not common in Tourette syndrome compared to other conditions, but it can happen. And these are movements that look like tics, but they're really not tics. So they are continuous movements of the body, usually of the mouth, of the tongue, of the neck, that are different than tics and might become persistent even after stopping the medicine. So we have to always monitor for those symptoms, because stopping the medicine early can avoid these becoming permanent. And these are things we keep watching. But as I said, they are much less common in people with Tourette syndrome than in other reasons to use those medicines, and we still don't know why. But it's good to know about that, to be aware. Again, they are the most effective treatment. We use them quite often, and they are the medications that have the FDA approval at this point. So these are the main medications that we have right now to help with Tourette syndrome. There are ones that we use not as commonly, and that will be botulinum toxin. Many of you would know the brand name Botox. This is based on one randomized trial and multiple case reports. It's currently used mainly for focal motor tics. So let's say a person might have a shoulder shrugging tic, or eye blinking tic, or head movement tic. These can be helpful for those motor tics that are focal and not complex. or if they have very loud vocal tics, and then will be injection in the vocal cords to try to weaken these vocal tics. More studies, of course, are needed, and then to know exactly what group of people would respond better, but they can be helpful if there is one simple tic that is interfering with a person's day-to-day life. Many people would require a combination of medications, whether it is for tics or for the associated symptoms, whether it's ADHD or OCD. And then this combination of treatments is usually done without like a lot of studies to help us guide which combinations of medications are better than others. But there is some studies for some of those combinations, such as, for example, combining guanfacine with aripiprazole. And this study, for example, seems to be showed quite success. And we know from clinical practice that that combination is helpful. And then, as I mentioned before, there is usually that combination that we want to do between treating the associated symptoms, so treating OCD as well as we are treating tics. So then you combine the treatment of OCD with the treatment of tics together, and it is usually synergistic to do that kind of treatment. It helps. It is helpful more than each one by itself. Right, then in terms of the more recent studies, now the aripiprazole is no longer very recent, but and you can see here the studies have been done and finished in 2014. The ones that have been more recent in the last few years have been what we call the VMAT2 inhibitors. I'm just going to use the pointer again. So the VMAT2 inhibitors are the valbenazine and deutetrabenazine. Unfortunately, both classes, although previous studies on those were promising to help people with Tourette syndrome, these studies did not meet their endpoint. So these studies were not successful in treating tics as much as we expected them to treat the tics. And the valbenazine was studied in both children and adults. And then all these studies were not successful. So at this point, these medications do not have FDA approval, and then it is hard to get these medications approved to use off-label because these studies also did not show benefit. One medication that is in trial right now and seems quite promising from the phase 2 results is the ecopipam that is currently in phase 3 study with an extension, and then we'll keep waiting for more and more of that medication to have more information about this. The interesting thing about this medication is that it's slightly different than the other antidopamine medications. The other ones work on something called the D2 receptor, and this one works on the D1 receptor, which might have less side effects that I mentioned before with those medications, such as like the sedation and weight gain. So we'll see as we learn more about this medication. Now, as I mentioned, these medications, the VMAT inhibitors, the tetrabenazine, deutetrabenazine, valbenazine, at least the last two here were the bigger studies. These bigger studies were negative in terms of benefiting people with Tourette syndrome. But there is a recent publication by Dr. Jankovic and Mahul that they looked at how they're using it in their own clinic. And then they are advocating for a persistent role of these medications. And they think that the reason the studies were negative is because the average dose that was used in these studies was lower than the average dose that is that is used currently in clinical practice. So the average dose of the tetrabenazine that was in the studies was 29.4. And the maximum FDA dose is 48, but in their clinical practice, they can go as high, they go usually as high as 72. So their reasoning here is that the reason these studies did not succeed, one of the reasons is that people were not allowed to go higher than the approved maximum of 48, and that's why many individuals could have improved if the dose was higher. Same thing with the valbenazine, where they, in their clinical practice, they go to 120, but the maximum dose in the studies is 80. So we'll see if more studies will be done on these agents or similar agents in the future. But at this point, the larger studies were negative. But I'm just sharing this real life experience that people still use them in clinical practice, although it is hard to get them approved by insurance right now. All right, we're going to switch gear a little bit about complementary and alternative medicine. I'm going to ask Dr. Cohen to speak in a bit about those that class. I'm just going to go quickly over the definition of what is complementary and alternative medicine. As you know, complementary and alternative, both these terms are different. Complementary means that you add them to the pharmacologic and other treatments, and alternative, as the name says, is an alternative approach. This is the definition of the complementary alternative medicine. So you have biologically based practices. So that will be like supplements and herbs and different diets and foods. Manipulative body-based practices like chiropractic approaches, mind-body medicine, so that will be like yoga, meditation, mindfulness, biofeedback, tai chi, qigong, biofield therapies, so aromatherapy, healing touch, and acupuncture, as well as other systems of medicine such as homeopathy, traditional Chinese medicine, naturopathy, or Indian traditional medicine. So these are all fall under that big umbrella. So as you can see, it's a huge umbrella of things. So it's always important to think whenever we're thinking about, especially if we're thinking here about that first group, the biologically based practices, we're thinking about vitamins, mineral, herbs, and amino acids. These are still things that we have to consider about what's the dose and what's safe. And then many herbal supplements can be toxic, like man-made chemicals. So it's always good to keep that in mind. And then so it's effectively, and this is an adage that humanity has known forever, is that the dose is the most important thing about toxicity. So it's always important to know, and that's why we need studies about these to help us know how much to give, and then what works and what doesn't work. And this is an infographic just to show that, for example, in pears there is formaldehyde, which is not good for us for sure, but the amount is very low and doesn't cause any problems. So it's why it's important to keep that in mind. It's the dose, not the presence of something that's the more important. So it's always important to keep safety first for both pharmacologic and non-pharmacologic agents when we're thinking about them. Many of you know Dr. Compoliti. She did a study with colleagues a few years ago now, asked people about, in her center, about the use of these complementary medicines, and then because many individuals don't tell us that they're using complementary medicine in the clinic, and then you can see here that 80% of people never ask their doctor about complementary medicine or alternative medicine. And that could be for multiple reasons. The reasons people use these medications or alternative approaches is to minimize symptoms. They feel that it adds benefit to the prescribed medication. Some are looking for a cure. Some believe that these approaches are harmless compared to the pharmacologic agents. Also, many people feel that's personal empowerment, something that they can control and work with. They could be related to cultural beliefs, and then very small number at the center, but that's a neurology center, so only a small portion replaced the doctor prescription with CAM approaches. Now, when asked about how much these approaches helped with their symptoms, 56% of people felt that there was improvement. No change in around 42%, and 2% showed reported some worsening. And then most people know about this by word of mouth, from friends, from internet, sometimes from a physician, and also from their therapist. And there, as you see, like these are the ones that were reported in that center about the most common modalities people use in their management. I'm going to quickly go through some and then let Dr. Cohen speak. About some of these some of the evidence we have. Many of those substances are not studied a lot or studied only in one study or like in feasibility or pilot study. So we don't have a lot of confidence in the evidence we have, whether positive or negative. So if we think of caffeine, there is concern that caffeine might worsen tics, maybe for some individuals, but in a study in 2017, 30% of adults reported that their tics worsen with caffeine consumption, and that could be because caffeine stimulates or allows or facilitates dopamine effects, and that could be one of the factors. Refined sugar possibly worsens tics for some people in terms of a survey assessment, and there could be a relationship between sugar consumption and also facilitating dopamine, but again, that needs to be more studied. Magnesium, and I will let Dr. Cohen tell us more about magnesium, but from the possible evidence is that there are multiple ways of thinking how magnesium can help by decreasing muscle contractions, by helping animal models with tics, by helping associated symptoms of anxiety and ADHD. And there was one study in 2008 that assessed magnesium in children. This study was in children for a 3-month period and showed a 68% reduction in the YGTSS score, which is a huge reduction. But that study was open label, so there was no control group. And as you know, there is a placebo effect that can make the effect of any intervention bigger. This same author at some point published that they're going to do a randomized study, but that never materialized. So I'm not sure exactly what happened. Dr. Cohen, do you want to comment on that and then tell us more about some of those CAM agents?
Okay, well, we could start with the magnesium.
Yes.
Personally, there's different kinds of magnesium, like magnesium citrate. A lot of people have given it to their kids. I was in a support group for family members that cared for people with Tourette's. And it became one just primarily for kids. And the ones with that took the citrate version had diarrhea and that. I strongly suggested they go to glycinate, which is assimilatable, it's very assimilatable, and it gave them quite a bit of relief. And to this day, they keep talking about magnesium glycinate. There's another form of magnesium which is still experimental. It's kind of man-made. It's magnesium L-threonate. That goes through the blood-brain barrier. That's the barrier that protects the brain from bacteria and other pathogens that might attack the body. The magnesium L-threonate seems to have really, really good, initial results, but I don't know. There just is not any scientific evidence. There's no double-blind studies. There's no anything. And this is true with virtually the whole list of alternative care, because it's the government subsidizes the pharmaceutical companies to do this expensive university-based study, and it's very, very difficult. Even the chiropractic, of which I'm a member of that profession, we had a hard time until one of our people became an NIH grantee, a National Institute of Health grantee, and then we started seeing hundreds of research, peer-reviewed, indexed research results come out on chiropractic, which I was pretty darn proud of. So that's what I know about magnesium. You should be taking it if you want to try magnesium. I would strongly recommend using B vitamins, and you even mentioned show here vitamin B6, but all the B vitamins are strongly recommended along with this, and that's what I know about magnesium. Some of the there's another thing that I've not tried, but I know of a hypnotist that's worked on a number of people with Tourette's, and he's had great success with hypnosis. That's something to try, something to look into. Another thing which I'm not an expert in is traditional Chinese medicine and acupuncture. And I saw one study that came out of Australia that had like a 26% decrease in symptoms. That was pretty amazing. Again, there's no double-blind studies, and so they'll say it's not scientific, but it is. Okay, and the one thing that I've been doing for 35 years is homeopathy. Homeopathy was started by a medical doctor, Samuel Hahnemann. And it was Samuel Hahnemann was doing a treatise on malaria. And the remedy of choice for malaria at that time was quinine. And he said it worked so well on people with quinine, he decided to take it himself. He was healthy. He decided to take it himself, and he got the symptoms of somebody with malaria. And so he says, I think we're on to something in German. So they started looking at other substances, poisons, things like that, and looking at the toxicology. If you look at the physician's reference, what do you call it? The big thick book that the pharmaceutical companies put out. It'll have all the toxicology of a substance you take. Well, you could take something like arsenic, and you could take something like mercury, and you could take other toxic things, even black widow venom. And if you can match that toxicology to the symptoms the person had, and give them a very, very diluted, I mean, one part progressively diluted, one part in 10, 30 or 40, 30 or 60 times, you'll get the opposite. So there's a book that I was reading on Tourette's, since I happen to be married to somebody with Tourette's, and she gets some real flares. A flare is when you know what a flare is, where a person starts ticking and they go through their usual sequence of actions. And I looked down this list of remedies that they recommend. There's 24 of them that they recommend for Tourette's. And there's one, argentum nitricum. Now, my wife, all of a sudden, her legs started flailing out. She was losing her balance. She had some other symptoms, and it perfectly matched the toxicology of argentum nitricum, silver nitrate. So we gave it to her, and darn if it didn't calm it down. It was brought on. Her condition was brought on by stress and anticipation of something that she was going to be doing, and that fell right in the line, and it worked. I can only tell you, I could tell you by just from my experience on what worked. I don't have anything. There's nothing in writing. There's nothing, no research, and that is a shame. That is a real shame. Vitamins. You talked about vitamins, B vitamins especially. The omega-3 oils. They seem to really be effective. The food sensitivities. This is another thing that I've been dealing with as a chiropractor and functional medical practitioner. Food sensitivities are not allergies, but where a person a person's immune system reacts to a certain food substance. Some people with Tourette's get flares from certain foods they eat. You could be tested. They'll look at IgG, that's immunoglobulin G, in the blood, and they'll see if it raises with the. They'll take a person's blood and they'll add a food substance to it, and if there's a change in the blood, then they say, well, and they grade it. But there's other food sensitivity tests too. There's a new one. It's called MRT. I believe in that. I've seen it and I took it for myself. It's been life-changing. And so food sensitivities is another really big thing. I'm talking really fast because I only have a minute or two to get everything out. But at any rate, that's my story, and I'm sticking to it.
Thank you.
And anything else?
No, I'm just going to go over some of those very quickly. As you said, we don't have much time left, but thank you.
My pleasure.
As you mentioned, there's a lot of limitation in terms of, because there's very little studies, and then that could be something we can, like as a Tourette association and then Tourette community, we can ask for, see if we can like ask the different funding agencies to see if we can have more studies done on those topics, so that we can know, because right now it's very hard to advise because we don't know. And then the most benefit, as you see here, like most of the information we have is anecdotal or based on very, very small number of open label studies, which makes it hard to assess really the benefit versus detriments. But there are some reports from people living with Tourette's. So dietary changes, some people go into an oligoantigenic diet. So that goes back to that inflammation hypothesis of Tourette syndrome, as well as the sugar-free diet, going back to the effect of sugar possibly. Some people also find that the Mediterranean diet helps with their Tourette's, but there's not very limited evidence at this point to recommend a diet change. Same thing with amino acid supplementation. But there is a study here that didn't show, like this type of amino acid called N-acetylcysteine didn't show benefit. Dr. Cohen spoke about the omega-3 fatty acids. There was one randomized double-blind study that showed that no effect on the tick score exactly, but an improvement in the impairment score, so how much people are affected by their ticks. Also, there is a lot of discussion about the relationship between the gut and the brain and how that affects TS. And then people with Tourette syndrome have a change in their gut microbes, but that seems to be different from person to person. So are we dealing here with different types of Tourette syndrome in different people? It's not clear. Some limited studies in humans in adjunct with neuroleptics included these types of bacteria as a combination and showed some benefit. Also, there is very few children that were treated with fecal microbial transplant. So that's taking feces from a person without Tourette's, making a liquid concoction of that's filtered. And so the bacteria are there, and then putting that through a tube into the intestine. And then that helped some of the children, but there's very few evidence right now. Only like a handful of children have been treated with this approach. There's also a possible effect of music. We know that people, when they're doing stuff that are engaged in, the ticks decrease, as you can see here. So that's their baseline ticks per minute. This is ticks per minute when they are doing music. But even after they finish music, their ticks decrease. And if they even simply imagine playing music or imagine music or even listening to music, their ticks decrease. So there is a signal there, and it would be great to evaluate that further. Dr. Cohen spoke about hypnosis and then acupuncture. This is one of these traditional Chinese medicines that has some of the strongest evidence, called Ningdong granules. These are the ingredients, and this is the amount used. There are different formulas for this. There's one that seems to work better, and that's produced by Zhao compared to Wang's formula. But again, I'm not a traditional Chinese expert, but these are and I'm putting the pictures here of the different components that go into making this granule. These are all very common components used in Chinese medicine in general. In terms of THC, there is a very recent study from Australia, published June 2023, that used an escalating dose of 5 milligrams THC, 5 milligrams CBD, so need that combination in a mixture, and then compared to placebo. And they started with 1 milliliter a day, increased weekly to 4 milliliters a day, so 20 milligrams each. And then divided 4 times a day. So they have to be no more than 1 milliliter a day, a dose, sorry. So up to 1 milliliter 4 times a day. They had 22 people, so it's a small size study, but it is randomized. And they showed that there was a significant reduction in the tic score, improvement in the OCD and anxiety symptoms, but as expected, some people, especially the higher doses, had some cognitive or memory issues. So it could be helpful for some individuals, and then that could give us some guidance about about the amount. But again, still small study, and hopefully more evaluations would help us. Again, also the availability of THC and CBD, the different formulas and preparations are variable, so we'll have to see the stability of those medications. Now, for stimulation techniques, there are 2 non-invasive ones called the transcranial, the direct current stimulation, and the transcranial magnetic stimulation, TDCS and RTMS. Currently, the evidence is conflicting. When we do sham, or let's the placebo version, these studies don't show benefit, but they are showing benefit in open label studies. So there are multiple variables that are reported as possible reasons for this. So hopefully more studies will show us. There is also median nerve stimulation. So that's a stimulation at the wrist that seems to have possible reduction in tic frequency and intensity. And there's also a randomized study with functional MRI, but very preliminary work that showed neurofeedback could be helpful. So using functional MRI as a neurofeedback mechanism can also help individuals with tics, but again, 1 study so far. So we'll see how these evolve over time. And the last slide is about deep brain stimulation. It's still not FDA approved, although there's a lot of information about it, but because most of that information is retrospective, is looking back at how people did. From the information we have, it is a 45 to 53% improvement in tic severity that is persistent for many years. And there is a big effort of combining all that information, and that's where we have that information about deep brain stimulation. It's a surgery where it will have a wire implanted into the brain, connected to a pacemaker-like device to help improve the tics. So given the time, I think I'm already above time. I'm going to finish here, and thank you, everybody.
Thank you, Dr. Deeb. Thank you, Dr. Cohen. We'll just take a few questions if you don't mind. I did put in the chat, if we are unable to get to everybody's questions, you can email us at support@tourette.org, and we'll work with the presenters on answering your questions. One question that I see in the questions is someone is asking, do the medicines that you take for anxiety and depression, would those interfere with CBIT?
So from the evidence, it seems that some of them, so depending on which medicines we're speaking about, but with the evidence that we have right now is that the medications that are in the neuroleptic family, so these are the antidopamine medications, seem to interfere with CBIT, make it less effective. We don't know about all the other medicines because it hasn't been looked at.
Okay, and then someone wanted to know what is CBIT/HRT?
Yes, HRT is a component of the CBIT. That's the habit reversal therapy, and CBIT is the comprehensive behavioral intervention for tics, which includes habit reversal therapy, as well as competing response and anxiety management and other components. So some people cannot access CBIT, so they can do habit reversal by itself or can do exposure therapy. So that's why sometimes we cannot offer the CBIT. So that's why it's the slash.
Thank you. And then we had a question about Botox. How does Botox injections help with vocal tics such as coprolalia? What does it do and how does it work?
We don't know for sure, but the way we think Botox works is that it doesn't work only at the area. So as you know, Botox, when we inject it, it paralyzes the muscle. It works on the nerve to prevent the nerve from sending the signal to cause the muscle to contract. But it doesn't stick there. We know from studies that the Botox itself travels back into at least the spinal cord. And there could be an effect on changing what we call brain plasticity, but it's not clear right now how Botox works. We know that people tried it in a study and then it works for focal tics and then like loud vocal tics, like including coprolalia, but we don't know exactly the mechanism of action right now.
Okay, we had just a few questions about the vitamins. They wanted to know, what is the best form of magnesium to use?
What was that?
The form of magnesium.
Oh, the best form of magnesium to use right now would be glycinate. But if you could try the L-threonate, see if that works. Life Extension sells it. Apex Energetics has it as well. That's more of a professional brand. That would, yeah. And let's see, who else would have it? Those are the two that I know, but a good health food store would probably have a good a version of L-threonate, magnesium L-threonate. But be very careful. The first time I personally took it, it lasted the whole next day too. I was kind of like spacey. You took it too, right?
What?
The L-threonate?
Yeah, I think I reacted very badly.
Oh, you reacted. Jill, my wife who has Tourette's, is sitting right here. She said she took it and it reacted with her. So stay with the glycinate for now until we can get it all figured out.
Okay, and then we'll do one last question. The last one is, have you heard of any studies regarding orthodontic retainers that can be helped with tics?
Yeah, that was a few years ago about like having like a device, like an orthodontic device and a spacer device. The evidence is still preliminary evidence. It's not highly supported with sham, with as much as sham as possible you can do with that. It's very hard to imagine a sham orthodontic application. Some people have noticed some improvement, but again, it's not clear right now scientifically.
Thank you. All right, well, thank you everybody for joining. This is all the time that we have for our webinar today. We had lots of information, so thank you, Dr. Cohen and Dr. D, for your time. Once the webinar is closed, you will receive a survey on the presentation. We would greatly appreciate if you could complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view the recording of the webinar. Additionally, the webinar will be posted on the TAA's YouTube channel for those who are unable to participate today, or if you missed maybe parts of it in the beginning. As always, we encourage you to reach out to us about this webinar or other ideas and suggestions that you may have. On behalf of the Tourette Association of America, thank you again for joining us and for taking the time to view our webinar. Have a great evening.
You too. Thank you. Thank you.